Thank you, everybody, for logging in tonight on behalf of Cardinal Contact Lens. We appreciate your interest in the ICD family of lenses, and we're excited to share some thoughts behind the fitting of this series of lenses. We'd also like to acknowledge Bausch & Lomb and Paragon Vision Sciences for co-sponsoring tonight's seminar, as well as Precision Technology on the other side of Canada that is now aligned with Cardinal Contact Lens. So let's start, before we talk about scleral lenses, with which patients need them, and also when is a scleral lens ideally called for, and when is it? And we might take this patient as a starting point and say, is this somebody that we should expect can achieve excellent acuity with glasses or contact lenses, or is it possible to fit this person with just simple soft lenses? One of the first things you might do is look at the lowest power that we can see, and we're coming up with about 40 diopters within the pupil. We find the steepest point within the pupil, and we're at 63 diopters. So there's a 23 diopter distribution of power within the pupil here. So for those of you with a corneal topographer, pull up your axial map, also known as sagittal or power map, and look for the distribution of power within the pupil. Is it symmetrically distributed? Is it wildly varied from one range of curvature to the other? And here's a patient that is most likely going to need RGP lenses of some kind, maybe a scleral lens, maybe a corneal GP, but certainly glasses or soft lenses are not likely to be able to mask this kind of irregularity. Well, if we put on a soft lens just for fun, what would happen? And of course, a soft lens that's around 0.06 millimeters thick or 60 microns is just going to take the shape of that eye. So whatever abnormal curvature this eye has, the soft lens is probably going to just mirror, mimic that shape. And that's obvious when you take these images here, and the one on the left is without a contact lens on a keratoconic patient. The one on the right is same eye with a conventional soft lens placed over top. And what you of course see is that soft lens is just utterly mimicked the shape of the eye. We really haven't been able to reduce the irregularity that you see within the pupil. So how is this particular design going to benefit this patient visually in any way, shape, or form? It's probably not going to. Now, there's an option that Cardinal provides you, which is called the Kerasoft, which is a very thick soft lens. These are dedicated specialty soft lenses for keratoconus, and what they do is through a much thicker medium, they're able to mask some irregularity, and actually quite an impressive amount of irregularity, just through that thick plastic. Now, if you consider that a standard soft lens is about 0.06 millimeters thick, or 60 microns, a Kerasoft might be 300 microns or 400 microns or more. And you can see its ability to mask what's there. Here's a patient that's post-LASIK, and we see without the contact lens this irregularity within the pupil. Place the lens on eye. On the right, you're looking at the map over top of the specialty soft lens. Notice how the contours seem to change. We're dealing with only two colors and less asymmetry. If you focus in on this white line here, this vertical line, and if we look at the powers distributed across the surface, there's a 2 diopter range from flattest to steepest without the contact lens. Then with the contact lens, we really tighten up those powers that run across this vertical meridian. Effectively, the thick soft lens is able to take out the high and the low points and give you a much smoother anterior surface. So we don't always need a scleral lens. Cardinal does have options for you when a scleral lens may not be the lens you need. There might be other options, and soft lenses certainly are easy for patients to tolerate. Now, when they aren't, when we can't seem to mask what's there, why is it that GPs are so phenomenal at masking the patient's irregularity? And of course, the rigid nature of a a hard contact lens or an RGP contact lens creates an anterior surface that's much more optimized for bending light. And here's a map over top of a GP lens on a keratoconic patient. And what do you see? An utterly smooth anterior surface, a spherical anterior surface. So any irregularity that might have been there is most likely to be corrected by this more optimized anterior front surface. So there's so many patients that benefit from GP lenses that we see, keratoconic patients, pellucid patients, patients that are post-refractive surgery, penetrating keratoplasties. All these benefit from RGP lenses and our ability to provide patients with much better optics to reduce the wavefront aberrations, the high-order aberrations that patients experience. The trouble is, with corneal GPs, we can't always achieve that optimal lens-to-cornea relationship. All of these fits you see would provide decent vision, but it would be comfort or fit that would be inadequate. And this is where scleral lenses really help. For instance, an ICD on one of those patients is going to vault over top of all that corneal irregularity and land out here where the sclera is much more symmetric in shape. So what the benefit of scleral lenses is it doesn't matter how bad the center is, you're going to vault over top of it by hundreds of microns, creating a very forgiving lens-to-surface relationship. Then land on the sclera where it's much more symmetrical, creating a comfortable alignment with the eye surface, and maybe most importantly, reducing the movement of GP lenses, and that's why sclerals are just so comfortable. But we don't just fit scleral lenses on patients that have corneal thinning disorders. There's a wide variety of benefits to these lenses in patients with ocular surface disease, with trauma to the eye, with the whole list, and I'll thank Patrick Caroline for providing this slide and some of the images here. So you can see that scleral lenses really aren't just for the abnormal anterior surface shape. They can be for an utterly normal shape, but with ocular surface disease. And here's somebody that we saw that was a significant benefit to scleral lenses in that here's the patient immediately upon walking into the clinic, and you can imagine how uncomfortable this person is with life, with each blink feeling like needles to the eye surface with so much exposed nerve endings. And then after 2 months of scleral lenses, we're able to achieve a much more healthy epithelial tissue, and this patient was completely different between this visit prior to scleral lenses and this visit after 2 months of scleral lenses. Was able to walk in without a seeing eye person, the relative that brought them into the first exam, and just had a whole change in their whole persona based on the wearing of these scleral lenses and not having that pain and that uncomfortable life that this person had had prior to being fit. And the beauty of scleral lenses is they trap that wet environment to allow the corneas to come back to some form of what we might call normal. Now, understanding the ICD is to understand what we know about the anterior surface shape, and Patrick Caroline and the team at Pacific University have been really key in helping us to understand what type of surface that we land on and how best to optimize the shape of that lens. And one thing the OCT has taught us, of course, is yes, the cornea is curved, but you'll notice at around 10 millimeters across the cornea to about 20 millimeters across the cornea, the eye begins to form this very straight line, or what you might call a tangent shape. You might also notice that we don't see a defined limbal junction. Here's clear corneal tissue where you see the whiter density of these pixels. That's where we have sclera, and in between, somewhere in here is the limbus. And we've generally been taught that the cornea, the curved cornea, meets the curved sclera, but that doesn't appear in the vast majority of patients. So one thing that the ICD is constructed based on is a knowledge that the peripheral cornea, the limbus, and the sclera are more tangent in shape rather than curved in shape. One of the next studies that we did at Pacific was to look at what is normal. If we took 55 normalized and looked at the nasal and temporal angles, what would be considered the normal tangent angle of the peripheral cornea, limbus, and sclera? And it works out to 38.4 degrees is roughly the average nasal and temporal angle of that peripheral cornea and limbus and sclera. Now, what about keratoconic eyes? Would you expect them to be different? Well, if you map out 55 keratoconic eyes, they actually have a very similar shape. They average about 38.25. So normalized 38.4, keratoconics on average 38.25. They're virtually the same in the periphery. So what does this tell us related to the ICD? Well, it tells us that we can construct a lens with the same landing for the normal eye as for the keratoconic patient. Now, angle doesn't mean a lot to most of us. We might think more in terms of depth, and the depth from 10 millimeters across the cornea to 15 millimeters across the sclera is about 2,000 microns in the normal eyes, and because keratoconic eyes have a similar angle, the average depth very similar there. So no major difference between these two groups. They have similar depths from 10 millimeters to 15 millimeters. Now, if we were to look at the cornea alone, there is a significant difference between the two groups. Notice normal corneas have a depth of approximately 1,750 microns. Now, what about keratoconic eyes? They were measuring in the order of about 200 microns higher. So it makes sense, doesn't it, that keratoconus is described as a corneal thinning disorder, and that's what we're seeing, that the action is happening within the cornea. Keratoconic eyes are bulging within the cornea. They're not affected by shape changes in the sclera. So related to ICD, what does this tell us? Well, again, it tells us that the shape of the periphery can be the same for normal and diseased eyes, but where they really need to differ is in the depth within the central optic zone of the lens. We need more vault in the center. So the ICD is constructed with some of this in mind, and one of those things is you'll notice that all the lenses are based on sagittal depth. In corneal contact lenses and in soft lenses, we think about base curve radii. That's our principal parameter that we're always aware of and that we record. With the ICD, it's in terms of the sagittal depth, because from this point on, the second you put on an ICD lens, everything you modify will be in terms of a change in sag depth. Do we need to alter the apical clearance? Do we need to alter the limbal clearance? And it's always about microns. It's always about depth. So notice the lowest sagittal depth trial lens, 3,900 microns, and then it goes up by 100 micron increments all the way to 4,900. The vast majority of patients you're going to fit are in this range. And then for very extreme cases, these will come up very, very rarely. You may need some of the highest depth lenses, the 51, 53, 56. And these are for real bulging eyes, the bulging corneal transplants and keratoconus globus. Otherwise, we're always operating in this range here. Now, another thing you'll notice is that we reference sagittal depth, but there isn't a reference to base curve. And that's because, again, we're always going to think about sagittal depth from this point on. Now, what happens when you put one different depth on versus another? Let's say we put on a 4,200 micron sagittal depth ICD, and that lens has X amount of clearance under the center. If you go up to the next higher lens, you're just adding more apical clearance. Go up to the next higher lens, you're adding more apical clearance. But look toward the outside of these red bars here, and notice going from a 42 through a 43 to a 44, there's really no change to the shape of this landing and the limbal clearance. What this tells you is going from one trial lens to the next, expect the fitting or landing of the lens to be the same, uniform throughout the trial set. The only major difference is you're going to be adding additional sagittal depth to the peak. So when we back up and we go to the sagittal depth slide with all the different trial lenses, we can fit a 42 or a 43 and not expect the fit to change significantly except for the addition of more apical clearance or less apical clearance if we go flatter. Now, another thing that we know is around the clock, the sclera isn't totally symmetric. These are the measurements of the scleral angles around the clock at 15 millimeters diameter. And what you see is there's about 1.7 degrees of differential around the eye. Now, is that a lot, 1.7 degrees? Basically, that works out to approximately 150 microns is the greatest amount of toricity on the sclera. And in the vast majority of cases, the scleral shape is with the rule. So if you imagine a with the rule cornea being steepest along the vertical, flattest along the horizontal, the sclera is generally similar in shape, but not always. The important fact here is there's about 150 microns of toricity. So the eye has a very depth around the sclera by about 150 microns. So is that a problem? Do we need a toric landing to the scleral lens? And the answer is no. And the reason for that is generally as the lens lands on the surface of the eye, it's going to sink into this soft, very boggy conge. And as it sinks in, it's going to take out whatever toricity is generally present. So you typically do not need a toric back surface in an ICD lens or any scleral lens because of this soft tissue that it's landing on. Even if it starts out with asymmetric landing, let's call it bearing on 2 points, it's going to quickly sink into this conge and seal itself 360 degrees around. So this is what happens. The lens lands on the surface of the eye, it squeezes out whatever fluid would be underneath this landing zone, creating this symmetrical bearing all the way around. And that traps the fluid in the center, and that's what helps us in the ocular surface disease environment, where we have all this fluid trapped in there, this bath for the ocular anatomy. The central epithelial tissue is bathed in this fluid as long as the patient has the lens on, and that's why there's such relief from scleral lenses. Now, what else do you notice? You notice the lens completely vaults cornea except for this little area here. Now, this is one that a lot of practitioners have a hard time with, and I have to admit I was in the same place when we first started using scleral lenses in general, and the ICD specifically. Does this need to be modified? And what you find is that the nasal aspect of the eye is generally higher in elevation than the temporal aspect. So what you're looking at is 7.5 millimeters out from center toward the nasal side. The elevation of the eye is higher than it is on the temporal side. As we go out even farther to 10 millimeters, that difference becomes far more profound. We're 320 microns of elevation difference on average between nasal and temporal at 15 millimeters, but at 20 millimeters, the difference is almost a millimeter depth differential. Now, so what? What does this tell us? Well, the scleral lens is going to hit the nasal aspect first and hardest. It's going to want an opposing point of bearing, so it's going to tilt its way and drop down farther on the temporal side and be closer on the nasal side. So what am I saying exactly? When you place an ICD or any scleral on eye, what you'll generally find is that there's a thinning on this nasal aspect. Now, is this thinning something that we should be accounting for? Do we modify the lens, or is it normal? And basically, it's normal. The eye on the nasal side is higher in elevation. The contact lens is going to be closer on the nasal side. The elevation on the temporal drops more significantly. Therefore, the contact lens wants to shift slightly temporal, and that also gives us this thinning on the nasal side. Now, lid force and gravity push contact lenses down, and that gives us the thinning up here at 12 o'clock. So the question is it touch? Does it need to be modified? Are we going to be bearing on the epithelium and disrupting cells? And what you might do is have the patient look in the opposite direction to the thinning. So the thinnings on the nasal side will have the patient look temporal. Notice how that area completely vaults. This is unlikely to be a lens that needs any form of modification. Same thing with this area here. Let's have the patient look in the opposite direction to the thinning. Look down and notice how that lens completely vaults as it skirts up ever so slightly. We'll talk a little bit more about adjusting the limbus, but have a look where the lens may be thinning, and if you're at all concerned that modifications may be necessary, just have the patient look in the opposite direction to that thinning. If you see it clear, chances are modifications are unnecessary. Now, how do we choose the first lens? And one of the things that's really beneficial is to just think in terms of height. What kind of height of eye am I dealing with? My trial set goes from a low depth all the way up to a high depth, so where do eyes fall? And of course, a refractive surgery, a post-refractive surgery patient is going to have a more oblate-shaped cornea, is going to be much lower in depth than a normal cornea. A steep cornea was going to be higher in depth than a normal cornea will be. Any form of corneal thinning disorder is most likely to be a higher depth eye, and certainly when we are dealing with penetrating keratoplasty and bulging cones, we might expect to need a much higher depth. So consider the type of condition that you're dealing with when you go to choose your trial lens. That's one of the best ways to choose your initial lens, not in terms of K readings, in terms of the condition. And if you have a corneal topographer, and specifically the Medmont, one thing that you can do is you can measure the height of the cornea as well as the angle that begins to form in the periphery, and that angle runs that tangent all the way through the sclera to where the ICD might land. And this could be a helpful way to choose your initial scleral lens because the appropriate depth of lens can be predicted every time. Of course, if you have an OCT like this particular instrument, the Vasanti, that will measure out to around 16 millimeters, you can just run a caliper across here and a ruler across here and measure the height of the anterior chamber, and that'll tell you which ICD to start with. If you have a corneal topographer alone, in the Medmont specifically, then you can take your corneal map and it will predict, based on that corneal sagittal depth and the angle that forms out here in the periphery, what the sagittal depth of lens that you might require. But do you need an OCT or a Medmont topographer to fit the ICD? You definitely do not. They're just helpful tools in selecting your initial lens. So if our topographer tells us that the predicted sagittal depth is 3,920 microns, we'll add in the apical clearance, and that tells us we need a 4,300 micron lens as a starting point. So the sagittal depth of the anterior chamber plus the fluid layer between lens and cornea tells us the lens that we need to pull out of the set. And this is beneficial because instead of putting on multiple trial lenses, the goal being we put on one diagnostic lens per eye. We don't mess around with putting lenses on, taking them off, putting on different sagittal heights, trying to find the one that's right. By having the right diagnostic equipment, it just makes you a little bit more efficient. Again, you do not need a fancy anterior segment depth topographer to figure out what ICD lens you need. So let's presume that we do not have a topographer that can measure height. How do you go about selecting the initial lens? Well, you know that a patient that has a normal cornea, maybe ocular surface disease, is going to have a fairly normal depth toward the low side, normal depth of eye. So you'll choose the 4200 lens. If it's a patient that's had post-refractive surgery and is slightly flatter than normal, you would choose a 4200 micron lens as a starting point. Or you could shave off 100 microns and pull out a 4100. But to make things simple, start with the 42 on any normal shape eye. If you're dealing with a keratoconic, you know the depth of that eye is a little bit higher, so you'll go up from 4200 microns to 4500 microns, a little bit more depth to account for the bulging eye that happens in corneal thinning disorders. If you're dealing with transplants, this is where it gets a bit goofy, but we've got generally higher depths in corneal transplants, but they come in all shapes and sizes. They come tilted, they come symmetric, they come oblate, they come prolate, so you can have all kinds of depths. Generally, it's better in trial lenses to start high. It's better to put on the lens with too much sagittal depth than call up the Cardinal consultant and say, I put on a lens that had 600 microns of apical clearance. Can you calculate the lens I need from that apical clearance? However, if you put on a lens that doesn't have enough depth and it hits the cornea, you have to put another trial lens on eye. So it's always better to err on the high side. But the point here is, if it's a normal eye, start with a 4200 micron ICD. If it's a keratoconic or a corneal thinning disorder, go 45. If it's a penetrating keratoplasty, go up to a 48. There's 4 principal zones in the ICD, and each is labeled according to its function. The central clearance zone should clear the central cornea. The next zone out, the peripheral corneal clearance zone, should clear the peripheral cornea. The limbal clearance zone should clear the limbus. And lastly, the scleral landing zone should be the only place the ICD lands on the surface of the eye. So let's go through each. Central clearance zone is curved, following the curved nature of the eye. The next zone out in the lens is the peripheral corneal clearance zone, and this is where the eye begins to form that straight line shape. So the peripheral corneal clearance zone, the PCCZ, is tangent in shape. Then the next zone out, the limbal clearance zone, is also a tangent, and this tangent is designed to link the vaulting of the central 2 zones to the landing of the scleral landing zone, but vault through the limbus. And then the final zone out in the lens is your scleral landing zone. Let's go through each section and what we're looking for. Now the central clearance zone, is ultra straightforward. All we're looking for is a lens that completely clears corneal tissue. We want no bearing on the cone or any part of the cornea. Ideally, we have in the neighborhood of 200 to 300 microns of fluid after settling. Less fluid tends to allow for better oxygen permeability, but in general you'll find that you can have 200, 300, 400 microns of apical clearance, and edema is really hard to come by in scleral lenses. Maybe because there's a small, tiny tear pump, maybe because a lot of oxygen is getting through the plastic itself, maybe we're sucking it through the lens or from the periphery, but we just don't see edema with our scleral lens patients, even though they're fit with a much thicker contact lens than most and with much more fluid layer in between lens and cornea. Consider if you have only 100 microns of apical clearance, will that be enough to allow for vault on the periphery where you may have a penetrating keratoplasty, a transplant with a very high spot, or a keratoconic with a bulging volcano coming out of one portion of the cornea. So having enough apical clearance generally allows for that lens to vault where the cornea may not be symmetric, where you may have a high elevation that's needed to clear. In an ocular surface environment, imagine that fluid layer, that bath between lens and cornea throughout the day, creating that wet environment that allows for a healthy epithelium. Now, how do we determine the apical clearance? with corneal GPs, we would say the apical clearance is adequate, it's excessive, it's inadequate based on how green the fluorescein appears. With scleral lenses, this is much trickier. It's hard to say what the apical clearance is based on looking at this pattern. This apical clearance could be 50 microns or it could be 500 microns. It's very tricky to tell. So in order to determine the right amount of apical clearance you're dealing with, what you do is pull up the parallel pipette in your slit lamp, look at your optic section, and take the known thickness of the lens. The trial lenses are 0.3 millimeters thick, or 300 microns, and you're looking for approximately equal lens thickness to posterior fluid thickness. You could use the thickness of the cornea, but of course if we're dealing with the corneal thinning disorder, we may not know the actual thickness we're dealing with at a particular area. So always better to use the thickness of the lens. In this case, our lens at the apex looks very similar to the posterior fluid. Maybe this thickness is slightly less than this thickness. But in this case, we have lens of about 30 microns thick. It looks like our posterior tear film is at least double that thickness. So it's in the neighborhood of 600 or 700 microns of fluid between lens and cornea. If you know the apical clearance, you can communicate this to Cardinal contact lens and they can help you to select the right final custom lens. Do you need to put on another trial lens? No. You can use this known clearance and modify from here. However, as I mentioned earlier, if you have touch, you have to put on another lens. You need to know what depth will clear corneal tissue. Now, next zone out in the lens is the peripheral corneal clearance zone, and this area is used most often in penetrating keratoplasty patients to bulge the optic zone forward when you've got a real bulging cornea. You can also use this zone to lift or drop the center by a small amount. As an example, if we have the standard ICD trial on eye and we want to take away a little bit of apical clearance, we could order peripheral corneal clearance zone -3, and that subtracts about 100 microns. Check out this angle here from this red bar to this red bar, and then compare that angle from here to here. Notice how it's gotten much closer to the surface of the eye, 0 being the eye surface. If we were to change that angle and make it higher like we have here, now we make that central optic zone bulge forward, creating more apical clearance. So when you have a peripheral corneal clearance zone minus, you're taking away apical clearance from the center, like you see here. When you order a peripheral corneal clearance zone plus anything, +3 in this case, you'll push the apex forward, creating more apical clearance. So the peripheral corneal clearance zone is used to just lift or drop the center of the contact lens, such as in oblate corneas or in bulging penetrating keratoplasties. The next zone out in the lens, going from center to periphery, is the limbal clearance zone. And what we're looking for here is, in white light, the fluorescein molecules running past the cornea, past the limbus, onto the sclera before they get squeezed out in the final zone of the lens. So ideally, our vaulting scleral lenses should clear the limbus. And this is what we're looking for in an OCT cross-section. Here's our contact lens, here's our posterior fluid layer, here's our corneal surface, and limbus is somewhere in this neighborhood, and you see the lens vaulting from the peripheral corneal clearance zone, coming toward the surface, the limbal clearance zone bringing it down into landing before we have our distribution of pressure in the landing zone. So the limbal clearance zone should clear the limbus. And again, if you see this thinning, have the patient look in the opposite direction to that bearing. If it clears, probably not something you need to worry about. If you are concerned, have the patient wear the lens longer, like 2, 3, even 4 hours or more. The longer the patient wears the lens, the more it will sink. The more it sinks, the clearer the picture you'll have, whether it's actually going to touch or not. So what we do is have our patients wear the lenses for 4 hours, if at all possible. Come back and see us. We'll check this out. If we see any of this thinning that we're concerned with, we can have the patient remove the lens, stain the eye, and see if there's any desiccation of the epithelium in this area. If there's none, then you know this is either fluid layer that's thinner here than it is here. It's not actual touch, it's just less fluid, or it's benign touch. It's very close to the cornea, maybe intermittently touching but not creating a rubbing type effect that's creating mechanical disruption of cells. So one of the rules you might follow is if there's less than 180 degrees of this thinning, it's probably not something you need to worry about. Just let it go, monitor the patient over time. If you see greater than 180 degrees of this thinning, then that's probably somebody that's going to have a lens that eventually, over the course of the day, is going to sink down, land on the cornea, and over time be rubbing on the epithelial surface. So this is one where you call up Cardinal Contact Lens and say, can you give me a limbal clearance zone +5? Can you increase the limbal clearance 5 steps to get that lens off the surface? So what's actually happening here is this is where we have a patient with a high scleral angle with more elevation. So our contact lens, as it sinks into the conj, which is normal, it hits this high point on the peripheral cornea and lands itself down. And over the course of the day, with the blinking and the eye movement, we're going to have this slight rubbing along here. We may have just a slight amount of staining. So it's likely that that needs to be modified. And what happens is when you order a limbal clearance zone +5, you go from whatever angle you are presently to a much steeper angle. The angle of this lens is coming away from the surface, creating more vault throughout the peripheral cornea, the limbus, and in the center as well. So limbal clearance zone +5 is the standard adjustment. Now the last zone in the lens is the scleral landing zone, and this is the only place the lens, should land down with a great deal of pressure on the eye surface. And what we want to see is that lens vault right through the cornea, right through the peripheral cornea, through the limbus, before there's some vault onto the sclera, onto the conj, and then we have this distribution of force out here on the final zone of the lens. For those of you with OCT, what you also want to see is a lens edge pointing along the surface, as if the angle of this scleral landing zone is equal to the angle of the surface it's sitting on. Another way you can look at it is if the apex of the edge is 50% into the conjunctiva, 50% above, you know that the tip is most likely pointing along. You've got this ideal relationship. So we call that a 50-50 edge, where 50% of the apex is in the air, 50% is sunk itself into the conj. Now the principal way to assess if the fit of your ICD or any scleral lenses is optimal is to look at the edge in white light, and what we want to see is all these small and large capillaries running right past the lens edge without any obstruction, so the vessels are able to freely flow right past the lens edge. If we have a tight fit, then this is something you may see where you've created a tourniquet-like situation where we've just completely cut off the vessel supply. And this is where the angle of the edge is too steep for the underlying angle of the surface. Just needs a simple modification. So what's happening when we have this blanching is this underlying surface angle of the sclera may be flatter than the normal angle of your ICD trial lens or your custom lens. Notice how the edge is pointing into the surface, not along the surface like this. Also notice the apex is into the conj, maybe by 80%, only 20% above. So this whole relationship of angle of scleral landing zone to angle of underlying surface isn't optimal for this eye. So this is a simple case where you call up the Cardinal contact lens consultant and explain it's mild blanching, and they're going to order a scleral landing zone -1. Increase the edge lift -1. If it's moderate blanching, then maybe we'll go to scleral landing zone -2. If it's more severe blanching, scleral landing zone -3. Now, why is it minus? To increase edge lift. And as you know, anytime we increase the edge lift of a contact lens, a soft lens, a gas perm lens, or a scleral lens, any increase in edge lift results in a reduction in sagittal depth. So with the ICD, any modification that increases central vault is plus, any modification that decreases central vault is minus. So just in summary, the way we would go about fitting the ICD 16.5 is rule number 1 is apical clearance. If the lens goes on eye and it hits the cornea, you should be going 300 to 400 microns higher in depth. If it becomes very easy to make out eye anatomy, where you may have a high point in the surface, you may want to add 200 microns more depth. If this is on insertion, it may not allow for the normal sinking of these lenses into the conch. The average sinking of a scleral lens is about, or at least an ICD, is around 150 microns. So over the course of the day, whatever apical clearance you have, you're going to have 150 microns less. So it's important to start with enough vault in the center to allow for that sinking. Here we see a keratoconic patient with just the faintest hint of where the cone is here. If we let that lens settle over the course of the day, will that settle into touch? It might be worth putting an extra 100 or 200 microns on if this is a trial lens and see how it settles and whether it settles into touch. If we have inadequate clearance to start with in the initial lens, then you may not have enough after it settles. This is the kind of thing we're looking for, a lens that definitely is clearing corneal tissue. Then looking from center to periphery, the next thing out we're looking for is, does the lens hit the peripheral cornea or limbus? Do we need to call up our Cardinal consultant and ask for a modification to the limbal clearance zone? And again, the typical adjustment is limbal clearance zone +5. Then lastly, look for the edge. If you have an OCT, look for an edge that's pointing along the surface, not into the surface. I've never seen an ICD that had too much edge lift, that was lifting up. Very unlikely for you to see that, but you may see with some frequency lenses that require additional edge lift. And this is probably due to the fact that the degrees of scleral angles are quite broad across most eyes. So some patients will get by with standard angle, some may need a much flatter angle because their underlying surface is much flatter. And when they do have that flat scleral angle surface, we're more likely to have a lens that slightly impinges, where we'd want to call up the Cardinal consultant and ask for a scleral landing zone -1. This one might be more like -2 because you're seeing greater than 30 degrees of that seal off or that blanching. If it's 30 degrees or less at any number of points, then you might go a scleral landing zone -1. If it's greater than 30 degrees, probably scleral landing zone -2 might be called for. So just as a bit of a test, let's presume we put on this lens and it was a 4,500 micron on a keratoconic patient. We measured the apical clearance to be around 200 microns after an hour of settling. So the lens hasn't completely settled in, and we see some thinning on the nasal side, superior as well, the same thing we expect to see on most eyes, where we get this arcuate nasal superior thinning. We'll have the patient look in the opposite direction, look temporal, then look inferior, see if these areas clear. If they do not, then we would order from the lab a limbal clearance zone +5. And it might be obvious from this OCT that that lens has completely laid itself down on the peripheral cornea, on the limbus, as well as throughout the scleral landing zone. So increasing the limbal clearance zone right here might be a way that we can get it off the tissue. Now there's just a couple other lenses we'll spend only a few minutes talking about. There's 3 lenses in the ICD family. The ICD 16-5 is the lens you'll use most frequently. It's the lens that works best on your highly diseased, your corneal thinning patients, your post-refractive surgeries, but you also have an option for a smaller lens. When an ICD 16-5, a 16.5 millimeter lens is difficult to get in a small fissure patient or a deep set eye, you might find the smaller version of the lens beneficial. Then there's also a toric, because there's a percentage of patients that have both toric scleras or they have some kind of residual astigmatism coming through the standard symmetrical lens, so you'll need a front toric as well. So here's the ICD 16-5 toric was constructed for 2 applications. One on the left where we have a highly toric sclera, maybe greater than the average of 150 microns, maybe 200 microns. We've seen at least one patient that required 700 microns of scleral toricity. Extremely rare, but it will happen. More frequently, you may see a patient that requires some toricity in the optic zone. So the 16-5 toric, using a small amount of back surface toricity, can create a rotationally stable fit. And here's an example where the toric lens has been placed on eye. You'll notice these 2 scribes they denote the flattest meridian of the lens. After settling of an hour, we're going to monitor whether that lens has stayed in the same place. Then we're going to physically rotate it off axis and see if it comes back to the same place. So you have 3 markers in time. How did the lens appear? What axis did these markers sit at before we sent the patient out the door? Then after the patient comes back from that hour or more of settling, are they still in the same place? Then we'll rotate those markers off axis and see if they return to the same axes. So what's important to note about the toric is it's not like soft toric lenses. These markers are not supposed to be at 0 and 180. They're supposed to be rotationally stable along the flattest meridian of the sclera, and that could be axis 45, that could be axis 90, could be 135. You never know until you place it on eye. What you want to communicate to Cardinal contact lens is, where do these markers find rotational stability? Is it 0, 180? Is it 45 and 225? Where is it exactly? Then when your custom order comes in, it should sit at exactly the same axes as the trial lens. So again, these markers are not meant to be at 0 and 180. They're meant to denote the flattest meridian of the lens, and they should find the flattest meridian of the sclera. Now, if your lens is rotationally stable, then you can imagine we can place a front toric power into the contact lens, and any residual astigmatism is addressed. Now there's also, as I said, a smaller version of the ICD, the 14-5, and this lens is helpful when you've got a really deep set eye or a patient that's struggling with insertion and removal of the bigger lens. It's beneficial in smaller corneas and maybe more normal corneas. It's constructed the same way as the regular ICD. You have 3 principal zones: central clearance zone, limbal clearance zone, scleral landing zone, same nomenclature as with the larger lens. And the 14-5, we fit it on virtually every eye shape. We've easily fit it on normal eyes, post-refractive surgery, and surprisingly, the smaller version of the lens can manage some keratoconus and some graft patients. But I'd be concerned with any bulging eyes. The smaller diameter lens cannot create as much vault as the big 16-5 can. So it's not the best for the bulging eye. A 16-5 lens is much better for those eyes. So contraindications for the ICD 14.5 would be any bulging cones or bulging grafts, as well as any larger corneas. 11.5 is probably the limit of normal corneas, normal corneal diameter that we can fit. When you get up to around 12 millimeters corneal diameter, there isn't a lot of real estate past the limbus to land that lens without hitting the peripheral cornea and limbus. So just consider bigger eyes are going to be tougher. Patients you will consider the 14.5 for are these normal shape eyes, these patients with significant amounts of corneal astigmatism that soft lenses can't manage. Patients where we've tried a bitoric corneal GP and we can't achieve the comfort. That's where a 14.5 ICD might be beneficial. As I said, smaller visible iris diameters, we don't need such a big lens as a 16.5, and those patients with real deep set eyes where it's hard to get the tissue out of the way to insert the lens without creating a bubble. Now there are 3 trial sets. The principal one that you'll likely want is the 16.5 lens, and you'll notice there's 14 lenses in the standard set. There's also a toric lens that's also a 16.5. It mirrors the symmetrical. So for instance, if you put on a 4200 sphere and you want to fit the patient with a toric or need to fit the patient with a toric, you put on the 4200 toric trial. The same depth of lens, the fitting is going to be very, very similar. Now the 14.5, also known as the ICD Mini, is a smaller range of lenses, 11 lenses. It doesn't include exceptionally high depths because it's not designed for the bulging eye. It's better on the much more normal shape eye. Now consider that the vast majority of lenses that you're going to use are within specific ranges. So if it's a normal cornea, they need a 42. If it's a keratoconic, it probably needs around a 45. If it's a penetrating keratoplasty, we probably need a 48. And the same thing with the Mini, a 3400 for normal eyes, 3700 for keratoconics, 4000 for post-surgical eyes or penetrating keratoplasty. So you can get away with a much smaller set. And I bring this up because you have some options. If you have a big specialty contact lens practice, you probably want the full ICD set. If you have a bunch of scleral sets that aren't performing as well as you'd like and you want to try the ICD, you're not sure that this is going to be the lens for you, then you can order the partial lens set, which includes 2 42s, 2 45s, and 2 48s. So you can get that partial set for much lower price. Then of course, you can get the ICD Toric as a full set or a partial set, and then you can get the Mini, the 14.5 ICD set, as a full set or as a partial set. And for those of you who have attended tonight, you're entered into a draw to win a free 18 lens family set, and this is another option that's available to you where it has 6 standard ICDs, 6 Torics, and 6 14.5s. And this is kind of a nice complete set in that it offers you an ability to fit virtually any patient that walks in off the street. So again, I would, if I were about to start with the ICD, I would definitely think about the 16.5 and get the full set, or possibly the 18 lens set gives you the ability to fit all 3 lenses. So the ICD is unique in that it's built based on a tangent construction, and you can kind of make that out, the straight lines that exist that follow the contour of the peripheral cornea and the limbus, and then you have this unique landing zone that's quite forgiving. And this is one of the advantages of the ICD. This surface that we use for landing allows it to be fit on a wide range of scleral angles. So having blanching problems with the ICD is far reduced than it is with conventional designs. For those of you who are really interested in sclerals and haven't had a lot of exposure, you may want to mark down this website, the Scleral Lens Education Society. This is a fabulous group of educators that have come together to assist with their colleagues and their understanding of how to fit these lenses. There's also an excellent patient insertion and removal and handling video available here. I think it's almost 15 minutes. It's a long video, but it's excellent for patients to explain all the different things they need to know about handling their scleral lenses, inserting it, removing it, overnight care, all those kind of things. Scleral Lens Education Society, a great group to be a member of. If you have more questions about the ICD and you'd like a little bit more comprehensive webinar or video on any of the components, the peripheral corneal clearance zone, the limbal clearance zone, the scleral landing zone, if you go to the ICD website, icdlens.com, there's a whole series of both short and long videos you can get additional information from. Now, for those of you who have attended the complete webinar tonight, you're also entered into a chance to win a $1,000 credit toward a Medmont corneal topographer. So if you're interested in an instrument that can help you design your RGP lenses, that can help you design your scleral lenses, that can assist in analyzing dry eye disease and your post-treatment ortho-K responses, basically anything related to specialty contact lens, this is the topographer that we recommend because it is a tool developed for specialty contact lens practitioners. So we'll be announcing the winners of the fitting set as well as the credit as part of the email with all your questions responded to on that same email. So I'd like to finish and just say thank you very much for attending the webinar sponsored by Cardinal, Precision, Boston, and Paragon. We really appreciate your time, and we'll look forward to responding to those questions in the next couple days. Thank you very much.